One of our presentations at ASH 2020 focuses on the data we generated from a single-arm phase 2 study using KOD therapy in patients with high-risk smoldering myeloma. This is a study that we initiated several years back, and we published the first enrolled pilot of patients in the JAMA Oncology Journal. What we have done now is that we have continued to enroll patients on this trial. So we have a large cohort of patients that have been enrolled. And because we started the study a long time ago, we now have also very long follow-up, so we can report and compare to other regimens. So in brief, what this study shows is that we can observe MRD negativity and CR in 66% of the patients. So that's very high compared to what you see in typical multiple myeloma patients. We also have a median duration of 5.5 years of sustained MRD negativity. We see when we look in further detail that it's very tolerable, and the rate of patients that drop off is very low. It's just 7% of patients that don't continue with therapy. The reason I point that out is because there was a recent paper in the Journal of Clinical Oncology when they gave monotherapy Lenalidomide. This was published in JCO 2019. There was a very low rate of complete response in that paper, and the discontinuation rate was as high as 51%. So here in this new combination with KOD in smoldering patients, we show very high rate of MRD negative CR and very low rate of discontinuation. And lastly, also, there is another study that uses the same regimen that we developed. They copied that and they integrated this with stem cell transplant. This is the so-called GEM-CSAR study. And if you look at their CR and MRD negativity rate compared to the KOD alone from the current study, it looks almost identical. There is no extra benefit adding transplantation, at least not in the GEM-CSAR study compared to this single-arm study. So I think the results are very, very provocative. They show deep, sustained MRD negativity without transplantation, and also much better tolerability than continued monotherapy with just lenalidomide.